but there's always a diminishing return with steroids. Like it doesn't help like it did the first time. And usually they get to the point like, well, that didn't help at all. And by then, their tissue is extremely damaged.
You're listening to the Ethos Athletes Podcast, where we believe that your health is the number one resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matt with the Ethos Athletes Podcast, and today we're going to be continuing our series on regenerative medicine for joint pain. And we're going to continue with this particular episode discussing using regenerative medicine, so PRP and stem cell therapy for elbow and wrist pain. For this series, we've had on special guest Dr. Ethan Kellum, who is an orthopedic surgeon and regenerative medicine specialist, and the owner of Nashville Regenerative Orthopedics. Dr. Kellum's also the former assistant team physician for the Boston Celtics. So, Dr. Kellum, welcome back to the show.
Hey, Matthew, thank you so much for having me. It's great to be here.
In this series, we've delved into the basics of PRP and stem cell. We've talked about how myself and Dr. Kellum approach joint pain. We've talked about how we use PRP and stem cell to treat different parts of the shoulder and the success that we've had with that. Now, today we're going to again discuss elbow and wrist pain. So, Dr. Kellum, let's start with the scenario that we did with the shoulder. Patient walks in with elbow pain. What are some of the things that you're looking at and that you're evaluating to see what's going on with their elbow?
Yeah, so the first thing when someone walks in with pain is to get a good understanding of who they are, what they do, how did this happen, how long it's been going on, treatments they've had before, and so you really want to understand, just everything about what's going on with them, and so you can put the whole story together. Whether they're right-handed or left-handed, what they do for a living, because all these things play into, their elbow pain, and so how active they are, what they do for activities, and so that'll kind of help you determine where you go from there. So a good history and physical are key in number one, and obviously using all the things that we've talked about before in the other podcast. But that's huge. That's critical. Really listening to the patient and understanding what's happening. Yeah, absolutely. Now, they have, at least in my experience, usually what I'm seeing is patients who have lateral or medial elbow pain. So it's also known as like golfer's elbow, tennis elbow. I've also seen some UCL injuries as well. Now, a little bit before this podcast, we discussed some of the things that you've seen. So you've seen those three in addition to a few other injuries. You want to chat a little bit about those as well? Yeah. So, the elbow is a small joint, but plays a pivotal role in getting your hand in space and where it needs to go. And so, the injuries that are very common to the elbow will kind of start on the lateral side. So you've got the common extensor tendons that are going to hook up into the bone, the end of the arm bone, the humerus. And so sometimes when that tendon there hooks in there, you can get what we call a tendinosis, kind of that fraying around those tendons where they hook in. And you'll get what they call tennis elbow. And so usually what we've seen is folks that, with their backhand and that muscle, tendon becomes very tendinotic and can cause a lot of pain. So that's one of the most common things. And then you've got underneath those tendons also kind of hooking into the same place on the arm bone as the lateral collateral ligament, right? And so that can be damaged and things like that. And then you move to the other side, so the medial side. And on the medial side, you're going to have things like the flexor, the common flexor tendon insertion. So when that becomes inflamed or damaged, you have what we call golfer's elbow. Also under that is the the UCL, or the medial collateral ligament. And that's the one that we hear a lot about with, from baseball players injuring themselves, especially as little kids. It's an epidemic in our kids, and the whole idea of Tommy John surgery and those things. And one of the things that we have to do to prevent that is one, decreasing the pitch count. And then, obviously some of the techniques that we do can potentially prevent those tears. And so those are the two most common things on the inside, the medial side, but you also will have the ulnar nerve that runs back there, right? So sometimes people talk about, well, I hit my funny bone, but it's normally that nerve that they'll hit, and it runs right underneath those tendon, kind of in between this tunnel. And sometimes that can get impinged upon. And so that's something that you also can treat with regenerative procedures. So that's a very common problem. And then if you look on the back side of the elbow, right, so the triceps muscle tendon will hook into the olecranon, that funny bone, the point of the elbow, I call it, and you'll have tendinitis in that, and also you'll see folks with olecranon bursa, so that swelling on the back. So that's a very common problem that can be treated. And then anteriorly on the front, kind of in the crease, a lot of people will have issues with the biceps tendon as it heads down the arm and then attaches onto the radius, one of the bones in the forearm. And so there's a lot going on around that elbow that can cause some problems. And it's mostly kind of overuse syndromes and injuries, people that do a lot with repetitive motions and whatever it may be. And so you got a lot to think about when you look at someone's elbow. And we didn't even mention the biggest thing, you can get arthritis in that joint, right?
Right.
So you got, issues within the joint that can cause problems.
Yeah, absolutely. So one of the things that we mentioned in one of our previous podcasts was we talked about, when we were talking about the shoulder, we talked about tendinopathy and treating tendinopathy. So just to quickly recap, a tendon is a muscle attachment. You can think of a tendon as a fastener that attaches muscle to bone, essentially. Now, we talked about tendinosis. So a lot of people have heard of tendinitis, which is inflammation of the tendon. But a more common injury is tendinosis. And Dr. Kellum, do you want to explain again what tendinosis is?
Yeah, and so that's, definitely that's a common, they're really different things. And sometimes people will use them interchangeably. But, with the tendinitis, you have this inflammation that's there. But with a tendinosis, what you really have is that there's no inflammation that's there, but really the tendon is damaged. And you can kind of think of it as partial tearing, or better yet, you can think about that nice new rope that you go to Walmart and you buy, right? And that when you buy it, it's nice and tight. There's no fraying to it. It's nice and strong. Versus when you have a tendinosis of a tendon, you now have fraying. It's still together, but you got fraying around it, and it's damaged and can cause pain. So they're really two different things. And when you think about that rope, you really get a good understanding of when you have a tendinosis to a tendon.
Right. And typically this fraying or the tendinosis and the fraying of that tendon can lead to pain. Sometimes it can lead to muscle weakness. And so it's not a comfortable thing to have, for sure. And obviously you don't want it to get worse and, it rupture or anything like that either, right? Like that's your worst case scenario.
Correct. Yeah.
So one of the things that, you mentioned a lot of really good injuries, and I'm assuming that you've successfully been able to treat a lot of these with PRP and stem cell?
Yeah, definitely. We have been able to do that. And I want to take a second just for a moment and kind of back up and talk about just like the normal treatments as an orthopedic surgeon
that'd be great.
That we have out there for these things and some of the potential problems with them, right? So, most of the time when we'll take something like the tennis elbow, people will start out with doing, they'll do a strap out there that can definitely help. Therapy and some of the modalities there. And I really like a lot of the modalities with therapy, right? Dry needling can help. Obviously, range of motion, strengthen those things can really help. And then, you can take anti-inflammatories, not the greatest things for your belly or for your kidneys, right? It's going to increase your chance of having high blood pressure. And then, one of the most common things that I really dislike is they'll say, "Well, you've got a tennis elbow. Let's inject that with a steroid, right? Let's inject a steroid in a local anesthetic." And the problem with that is that steroid is now going to damage the tissue. And so, it was always interesting when I was in residency and I was learning. And of course, as a surgeon, folks would come in and say, "Well, we're just going to inject this," and we inject it. And my attending would always say, "Well, we only do 2 injections." Well, as time goes, I found out why we only do 2 injections, because usually by that second injection, they're going to rupture their tendon, and then you're operating on them. So, it can potentially help things a little bit, but really ultimately damages the tissue, and then you're kind of forced to have surgery. And I see that a lot with when you're treating things with steroids. And so, some of the very common modalities can definitely help. Once again, therapy and some of those modalities, I really like things like infrared and laser, certain sleeves that can help with making more infrared. But steroids and I like to stay away from. And so when you're kind of putting all those things in there, and then you're looking at this common problem, it's like, well, gosh, there's got to be something else out there, and that's where kind of stem cells and PRP come into play.
Yeah, and that's a fantastic point to make. And one of the things that I'd like to ask, or maybe our listeners are even asking, is, okay, well, and I don't know if you have the answer to this, but if a steroid injection or cortisone or whatever it is causes that much, or can cause damage to that extent, why is it done?
It's done because it's when steroids was first discovered at Mayo Clinic in the early 1950s, it was it was a godsend for so many patients, right? It's like it was a miracle because we didn't have anything else. There was like, well, you just kind of live with it. We knew nothing else. And we've kind of been in that mindset for the last, almost 70 years,
right.
which is crazy to think about. And so, it's something that can help immediately, right? So, pain relief, and that's always our goal, is to get someone out of pain, because normally by the time they come to see us, they're hurting so much. And so, that's why it's so prevalent, is because it can make an immediate response,
right.
As far as it can help immediately, but ultimately, like we said, it damages the tissue. But that's why we haven't for a very long time had anything better to offer.
Yeah, no, it makes perfect sense, and it's like you said, I mean, it works really well for knocking out the pain and really shutting that off, but a lot of times it's temporary too, right?
Very temporary. And so steroids are very interesting. It's always, people will have that one and it may work really great, and then you don't know how long it lasts. And then like they're going to get another one, but there's always a diminishing return with steroids. Like it doesn't help like it did the first time. And usually they get to the point like, well, that didn't help at all. And by then, their tissue is extremely damaged.
Yeah. Have you found that if individuals responded even temporarily to steroid use, that they would likely respond very well to PRP or stem cell?
Well, what I would say, because I try not to inject any steroids at all.
That's fair.
And so, but what I would say, if they respond to kind of a diagnostic injection, meaning that we do something like a ropivacaine or something like that, normally when I find that happens, they do respond to a regenerative procedure, because it lets us know that, hey, we're treating what we're after. And now that relief is going to be very temporary, a couple hours.
Yeah.
But it allows me to see that, hey, then they're more than likely going to respond, if they're going to respond to a regenerative procedure, that we're after the right thing with it. So I definitely see that.
Yeah, absolutely. And that's kind of, that's been my experience as well, is that we'll do a diagnostic injection of I use lidocaine and block it. And then if the pain goes away, it's like, okay, then we know exactly where the pain's coming from. Based on the injury, you'll likely respond well to PRP or stem cell therapy. So or prolotherapy, even if you wanted to.
Right. Yeah. Prolotherapy is a great one. That's one that I like to use, because then it has some healing properties with it. So that's a really good one.
Now, as we've advanced in medicine and found, like you said, found other alternatives to cortisone with these regenerative medicine therapies, I think, at least from what I've seen, the elbow and specifically an epicondylitis, so like a golfer's or tennis elbow, that those have a lot of research that behind them with PRP and stem cell that really back the efficacy or how well it works for those two things. Have you seen the same thing?
No, yeah, there's definitely very good research out there for those things, and it's one of the ones that we're into knees and into shoulders and all those things now. Right. But I would imagine, and for me, the very first thing that I saw treated with a regenerative procedure was a tennis elbow, and so obviously we do it for every joint and every tendon now. But 5 years ago, when I first saw that was the first thing I experienced. So there's some very good research that points to hey, this definitely helps.
Yeah. Now, one of the other things that you mentioned earlier that I'd like to touch on is actually using it to prevent, or using PRP or stem cell to prevent like a UCL injury that you mentioned. That's huge for baseball players. I mean,
yeah.
Or anyone with a UCL injury, but baseball is the common one that it occurs, right? Like that's
correct. Yeah. So and I think that we as physicians, we do a very poor job of prevention, right? Prevention is really, we have what they call sick care versus well care.
Right.
And we really should do well care. And that's one of the great things about my practice and folks that come in to see us is that, some of those folks are looking to prevent some things. And it's kind of one of those things when folks would ask me about that, and I was kind of taken aback and going, man, I don't know if I can do that, because that wasn't my mentality, which it should be. Like, we shouldn't wait till there's a problem. We should try to prevent problems. And so I think, these kids that are just pitching their arms out, and I mean literally pitching their arms out. Yeah. That one, we've got to help prevent that, one, with the number of pitch counts, right, and protecting them, and two, potentially doing things like this, right. So if we identify folks that are having issues with the ulnar ligament, as in they have tenderness, they have pain, those people ought to rest, but they probably ought to have a regenerative procedure to help heal that back, and I think that'll keep them out of trouble.
Are you able? So when you're evaluating these patients for prevention, are you seeing any kind of changes on like the musculoskeletal ultrasound that you're using, or is it just I'm having pain in the area? Let's take a look and evaluate, stress it out.
Yeah, so on ultrasound, you can definitely see some thickening. You can see what we call hypoechoic areas. So you can have these tears, and they doesn't light up as well. And so you can definitely see those things, but mostly it's going to be with physical exam. Mm-hmm. And things like that. But obviously MRI can tell the story very well. And you can definitely see with folks if they have some issue where it lights up on the MRI, and then you treat them with the regenerative procedure, and and sometimes the MRI may lag behind their physical exam, so they may be healed and may be better on physical exam. But you get a year down the road, and you take an MRI, and you'll see that tendon is healed. And so it's a very powerful technology that we have and can make some differences. And we see that once again by physical exam, their subjective data that they're telling us, like, hey, this feels better. And also with some objective data when we're looking at the MRI down the road.
Yeah, absolutely. We talked about cortisone earlier being like a temporary fix for some of these, kind of like a Band-Aid essentially for these injuries. How is PRP and stem cell, in your experience, how does that relate to cortisone's efficacy?
Yeah, so the biggest thing is, number one, it's not going to hurt the tissue, not going to hurt the patients. That's number one.
Yeah.
Number two, and because stem cells and PRP, especially when you're dealing with a joint and things like that, the word like completely healing, people throw that around all the time, and I think that it definitely can decrease your pain. It can make the cartilage that's there better. Is it going to make new cartilage where there is none? It's not going to do that.
Right.
And at times with a joint, it can get you out for a very long time. Is it a cure all the time? No.
Right.
But I would tell you though, for things like a tendinitis, man, it can actually. I've seen it heal those things, like totally cure that. And so, having these things, and then it's better. It's fixed.
Yeah, no, that's perfect. And that's the great thing with these therapies is it does work that well. I mean, if you're using it right, if you're using it to treat the proper thing,
correct,
you get a really good result with it. And it's a long lasting result as well.
Yep, definitely can be.
Yeah. So we discussed the elbow. Let's go into the wrist a little bit now. Unless you want to add to the elbow.
The wrist. There's so much going on in the wrist.
So in my practice, I've seen a handful of wrist things. I definitely see shoulder, knee a lot more. Elbows also up there. Wrist is a little bit less so. At least in the let's walk through the same thing again. Someone walks in with wrist pain. What are the different things that could be going on with them?
Yeah. So wrist pain, once again, very, very common. Once again, an overuse issue a lot of the times. Also arthritis. And so you kind of think about, you just kind of take the anatomical parts that you're going to have. You're going to, you do a good history and do a good physical exam, and then figure out what's happening when it happens. But you're going to take, you're going to kind of start on the radial side, right? And you have starting on the radial side and kind of going over the top of the wrist, right? You have these 6, what we call dorsal compartments, and there's tendons that live in these 6 compartments. Some of them have 1 tendon, some of them have 2, some of them have 4, but there's tendons that lie and they allow you to extend your fingers and wrist and things like that. And so sometimes these tendons will run over one another, and when they do, it's like you can imagine they rub on each other, and they can cause pain. One of the big ones is the queer veins that you'll see a lot in folks that are pregnant and with just overuse. And so you're kind of once again you can get a tendinitis or a tendinosis in all of those tendons. So those are all places on the top of the wrist that can cause problems. And then you're going to move more up to kind of the ulnar side, and on the ulnar side, and people hear a lot about this. Well, gosh, I injured my TFCC, so it's just the triangular fibrocartilage complex that kind of has a little tissue in between some bones, but it's on the ulnar side, and you can tear that, and it can cause some significant pain. I will tell you, as a surgeon that has done a lot of arthroscopy, and we go in there and we'll put a little scope in there and we'll try to debride that tissue. Even some people will talk about repairing it. I've never seen in my time that work out very well when operating on it, but I know that doing a regenerative procedure on that helps really well. So you got that on the ulnar side, and then you're going to kind of come back around, and now you're going to be on what we call the volar side, or kind of the palm side. And so as you go across, you have the flexor tendons that are going across there. But one of the big things that you have over there is the carpal tunnel. And, when that nerve is impinged, there can cause some issues. And you can treat that with some regenerative procedures. Also, probably one of the biggest things that you'll treat around the wrist is folks that have that Cmc Joint Arthritis. And so that's where the thumb kind of comes down. They'll have trouble opening a jar or a door, and they'll have pain right at the base of that thumb. And so you get a lot of arthritis that's there. And that can cause significant pain, but can be treated regeneratively as well. And then you've got some of the ligaments, the big ones, like the scaphoid lunate ligament, and you can get some widening there. And obviously all the joints inside there, right? So there's a lot of little spaces in there. The distal radial ulnar joint, you have the radial carpal joint. And so all these things can get some arthritis in there. And those things can be treated with regenerative medicine as well.
Yeah, no, that's great. And you touched on a lot of the big ones. Like you said, the TFCC is the one that I've seen the most in my practice.
Right.
And then the arthritis that you mentioned, those are the most common ones. Now, with carpal tunnel, we discussed treating the nerve in the previous podcast episode, I'm assuming, are you using platelet lysate for that piece as well? Or are you using PRP?
Yeah, so, I definitely think that you can use PRP around that, but I think that nerves respond very well to when the platelets are broken open and the growth factors are just kind of hanging out.
Yeah.
And can affect things. So you do what we call a Hydra Dissection around that. You essentially put the platelet lysate around those nerves, creating more space and also giving some healing factors of those things. And people can respond to that and create a little space in there, decrease inflammation, decrease pain.
Yeah. And good.
No, yeah, and just people can do really well from having that done.
Yeah, and for those of you who haven't seen one before, which is going to be the majority of our listeners, a Hydra dissection is actually a really cool procedure because you essentially go and find the nerve under ultrasound, and you can see where it's at, and then once you go and start injecting, you see the nerve kind of just float away from the injections or from your needle tip, and it's just kind of floating away. So you're able to push the nerve away from the other structures around it, kind of isolating it and making sure that it's surrounded completely with PRP or stem cell, whatever you're injecting. It's kind of cool to see, at least. I mean,
yeah,
on the screen. So you mentioned those things. Is there out of the different injuries that you've seen on the wrist, is there some that respond better to regenerative therapies compared to others, or are they all kind of even across the board?
Definitely in the hand, I would say that's all pretty even. The things that you're going to treat the most of, once again, are going to be that Cmc Joint Arthritis, going to be that TFCC injury, and then arthritis within there, and all those respond fairly well to a regenerative procedure.
Yeah, that's perfect. Have you done any types of surgeries on the hand? You can compare the results of the surgery on the wrist and hand compared to regenerative therapies, or is that
well, it's like I mentioned about the TFCC. I mean,
yeah.
You can go in there and scoping those things. People just don't do well from that, and so it's a tough thing because now you made them different, right? It's changed. All you've done is surgery, and you're trying to make them better. And so things like that, in anything, quite honestly, like I would try a regenerative procedure before I would try surgery, and see if I can make what's going on, better.
Yeah, no, that's perfect. Is there anything else you'd like to add for the hand and wrist?
I think we covered most of that as far as what's going on. The only other thing, there's other nerves in there that you can potentially treat, the radial nerve, ulnar nerve as it goes down. But we covered pretty good with the wrist. Wrist can be a little complicated, but if you take it kind of stepwise, you'll get a good sense of what's going on and what needs to be treated.
Yeah, today we discussed using regenerative medicine to treat the elbow and the wrist, and that it shows a lot of good success in being able to treat a lot of injuries in these areas. And we also discussed the pros and cons to using cortisone versus these therapies, as well as some surgeries. I wanted to ask you one more question. I don't think we talked much about the surgery aspect on the elbow. Have you seen any difference with, let's say, you had to do a surgery on the elbow, or how often have you had to do a surgery since you started doing regenerative medicine on the elbow? And then if you have done it, have you augmented it with PRP or stem cell procedure as well to help the healing go by faster?
The nice thing about the elbow is that it's a superficial joint,
right?
And so a lot of these things are very amenable to doing a regenerative procedure, and so that's going to be the main thing as far as my treatment for those things. That's what I'm going to start with, and hopefully, and usually end with. There's definitely times when I'll scope an elbow. Like I have one coming up where this guy, he's a younger guy. He had an injury to it, and from his injury, he's gotten stiff. Now he's got synovitis and all that stuff. He has the picture of a tennis elbow on there. We'll treat that, but his deal is mostly that his capsule is now stuck. So we're gonna go in there, release that, and then we're actually going to follow him up with the regenerative procedure, just because it's going to help us with healing and hopefully get him to a place that he'll do well. But surgery is definitely the last resort, especially if you do it right. If you come with a regenerative procedure first before a steroid, you usually can help folks and keep them away from the OR. And then, surgery is going to be the very last result, but they've got to be in a bad place, and either they've let it go for too long, or they've had, some kind of steroid or, a major injury where it's completely torn or things like this.
Yeah, that's perfect. Awesome. Well, I think we covered a lot today. We were able to get out some good information to our listeners. So
yeah,
Dr. Kellum, thanks again for being on this podcast.
No, you're very welcome. Very welcome. Thanks for having me.
And everyone, thank you for listening, and we'll catch you on the next one.